The project I will present today is titled Delayed Diagnosis and Presenting Characteristics of Acanthamoeba keratitis at a Tertiary Medical Center. Acanthamoeba keratitis, caused by parasitic free-living protozoa found in air, soil, dust, and drinking and seawater, is a severe corneal infection resulting in significantly impaired vision and ocular morbidity. Here is a diagram that illustrates how Acanthamoeba causes infection. In cases of a corneal infection, Acanthamoeba are attached to the corneal epithelial cells through the mannose binding protein. It then causes destruction and apoptosis of the corneal epithelium and stroma, both by direct phagocytosis of corneal cells and by various proteases. Delayed diagnosis increases the risk of amoebic penetration through the corneal epithelium into the stroma, making the condition more challenging to treat and increasing the odds of worse visual outcomes. The ability of Acanthamoeba to attach to biological and inert surfaces with the help of Acanthopodia contributes to its presence on biofilms from decay products of bacteria found on many moist surfaces, such as contact lenses. Thus, it is not surprising that previous literature indicates that contact lens wear is the primary reason for the increased prevalence of Acanthamoeba keratitis in developed countries, like the United States. Clinical signs vary depending on stage of disease, but previous literature cites ring infiltrate and radial keratinoiditis as classic signs of Acanthamoeba keratitis. Here is an image with the previously described signs of Acanthamoeba keratitis. In particular, I would like to point out the classic ring infiltrate in image A, where you can see the central corneal haze with a paracentral demarcation ring, characteristic of Acanthamoeba keratitis. I would also like to point out radial keratinoiditis, which is considered pathognomonic, in image B, in which the patient has an irregular and hazy appearing epithelium. Diffuse and multifocal infiltrate in images C and D respectively were also clinical signs found in our study. In addition to varying clinical signs at presentation, the actual confirmation of diagnosis is often delayed and thus linked to poor visual outcomes. Primary providers lack access to the necessary tools for culture and pathology confirmation that are readily available at a tertiary care center like Wilmer Eye Institute. For example, polymerase chain reaction testing for Acanthamoeba DNA has been shown to increase rates of diagnosis to 90%, but PCR is not commonly used outside of academic institutions. Previous literature also cites that potassium hydroxide wet mount preparations have high sensitivity and accuracy in identifying Acanthamoeba trophozoites and provides instant results. Finally, confocal microscopy is another method used to diagnose Acanthamoeba keratitis and has excellent specificity, but again, is usually only utilized at tertiary care centers and requires an experienced interpreter. Even if Acanthamoeba keratitis is suspected based on clinical presentation, these challenges in obtaining microbiologic testing, as well as delayed referral to tertiary medical centers, represent barriers to timely definitive diagnosis. And so, despite increased awareness of Acanthamoeba keratitis in recent years, diagnosis is often still significantly delayed. The purpose of our study was to describe time to diagnosis and initial presenting characteristics of culture-confirmed Acanthamoeba keratitis cases seen over a 7-year period at a tertiary academic medical center in the United States. Our goal was to provide additional data for clinical signs and trends, as well as suggestions for more timely diagnosis and effective treatment of Acanthamoeba keratitis. This study was a retrospective review of all culture-confirmed Acanthamoeba keratitis cases seen at Johns Hopkins between August 2012 through June 2019. We collected data on the time from symptom onset to culture collection, presenting and final logMAR visual acuity, misdiagnoses and treatments prior to referral, previously described risk factors for Acanthamoeba keratitis, symptoms and slit lamp examinations findings upon referral, and prevalence of co-infection. Differences in continuous variables were assessed via t-test. After looking at the demographic characteristics, we found that there were 45 eyes of 43 patients with confirmed cultures. 2 patients had bilateral infection, one of which was a sequential case, meaning one eye was first affected and then the patient later developed an infection in the other eye. The other was a case of simultaneous infection in both eyes. The mean patient age was 41 years, with a range of 16 to 72 years of age. There was an approximately equal distribution of male and female patients, and a slightly greater proportion of right eyes to left eyes. When comparing initial visual acuity at the time of referral between early versus late diagnosis, we found no statistically significant differences between these two groups, with early diagnosis being defined as less than or equal to 28 days elapsed between symptom onset and date of culture, and late diagnosis being defined as greater than 28 days between symptom onset and date of culture. However, when we compared visual acuity at final follow-up, there was a trend towards statistical significance between early and late diagnosis, indicating that patients diagnosed late tended to have worse visual acuity at the date of last follow-up. A key finding of our study is the characterization of referral patterns of patients prior to presentation at a tertiary institution, which, to our knowledge, has not been analyzed in previous studies. When we examined management prior to referral, we saw that 69% of eyes were seen by an outside ophthalmologist prior to being referred to Wilmer, and 27% were evaluated by a provider other than an ophthalmologist. The data also showed that 31% of patients had a delayed diagnosis of less than 28 days, whereas 69% had over 4 weeks of elapsed time between symptom onset and diagnosis. When we look at initial diagnosis before referral, we see that 29% of patients had no diagnosis ascribed to them at the time of referral, 38% of patients had been misdiagnosed with herpetic keratitis, and 22% misdiagnosed with bacterial keratitis. As a result, 71% had been prescribed topical antibacterial medication, 40% antiviral, 42% corticosteroid, and only 9% and 7% were prescribed topical and systemic antifungal, respectively. In our Western developed country patient population, 96% of patients had a history of contact lens wear, largely for refractive purposes. Beyond contact lens wear, 9% of patients had recent eye trauma, 4% had severe ocular surface disease, 16% had some other form of ocular surface disease, including mild to moderate dry eye. 7% had previously diagnosed herpetic keratitis before the current round of symptoms had ever started. 7% had a history of LASIK, and finally 4% had a history of systemic immunosuppression. When we look at symptoms upon referral, we found that 82% of patients had some form of eye pain. The remaining symptoms of blurred vision, photophobia, tearing, foreign body sensation, and headache were common but nonspecific. It is worth noting that out of the 37 eyes with pain, although 51% had severe eye pain, 18% of patients actually reported no pain at all. Slit lamp examination findings upon referral include 56% of conjunctival injection, and interestingly, 38% had diffuse infiltrate, 36% had deep infiltrate, 31% had multifocal infiltrate, and only 11% had the classic ring infiltrate. 29% of eyes had another pathogen isolated on initial culture collection. In addition to Acanthamoeba, 5 eyes had P. acnes co-infection, which could have been a contaminant from the skin. 4 eyes had coagulase negative staph, 1 eye had MRSA, 1 eye had strep viridans, 1 had staph sacroiliticus, and one had Bacillus cereus. Here, I just want to summarize a few key findings. Majority of the 45 eyes of 43 patients in our cohort were not diagnosed via culture for over 4 weeks after symptom onset, with a mean of 53 days from symptom onset to diagnosis. Late diagnosis was associated with worse visual outcomes with a trend towards statistical significance, despite a sample size of only 45 eyes. This is consistent with previous reports that state later diagnosis results in worse visual outcomes. Misdiagnosis was common, as 69% of eyes were initially misdiagnosed and treated as a non-Acanthamoeba infection, likely due to mimicry of other forms of keratitis. Of note, 38% were misdiagnosed as herpetic keratitis. When we looked at the distribution of exam findings, the classic ring infiltrate and radial keratitis were actually less common compared to nonspecific findings such as diffuse, deep, and multifocal infiltrate, as well as conjunctival injection. Co-infection was common in our cohort and may have contributed to nonspecific examination findings. Pain reported was also less severe than previous literature described, with 18% reporting no pain at all. Here are suggestions for future treatment implementation based on key findings in our study. The most obvious conclusion is that general ophthalmologists and optometrists, the main point of contact for most patients, should emphasize proper contact lens hygiene to reduce infection incidence. Primary eye care providers should also avoid treating keratitis with antivirals or topical steroids until Acanthamoeba keratitis has been sufficiently ruled out. Furthermore, the absence of pain should not lower the threshold to culture for Acanthamoeba keratitis. Many studies have attempted to characterize classic presenting signs, but our study found no specific pattern of clinical signs, since diffuse, multifocal, and deep infiltrate are nonspecific and also present in bacterial and viral keratitis. Because of this, in addition to co-infection possibilities, it is critical to not look for a specific constellation of signs and consider Acanthamoeba keratitis in a presentation of atypical keratitis in a contact lens wearer. Inevitably, part of the diagnosis delay is the inability of initial primary care providers to perform Acanthamoeba testing. The development of a rapid PCR test for Acanthamoeba that can be deployed in the office setting may improve both diagnosis rates and times. Alternatively, a potassium hydroxide preparation may be considered in the outpatient setting, allowing the ophthalmologist to start empiric treatment immediately while waiting for cultures. Studies evaluating the ease and economics of a potassium hydroxide preparation for diagnosing Acanthamoeba keratitis in the primary eye setting should be done. Establishing better strategies in the primary eye setting to test for and diagnose infection is critical to decrease the time from symptom onset to diagnosis for better final visual acuity. My personal contributions to the project includes chart review and data collection, manuscript writing and editing, and literature review. I would like to thank my fellow collaborators and especially my PI, Dr. Warretta, for giving me the opportunity to contribute to this project. Thank you so much for taking the time to hear my presentation today.